All right, we are group 1 and we are talking about Alzheimer's and dysphagia from Allison, Emily, Carly, Abby, Gabrielle. So Alzheimer's disease is a progressive degenerative neurological disease that causes a common type of dementia. This disease is characterized by deterioration in personality, cognition, memory, language, and communication. The greatest risk factor is age, and they have an issue initiating feeding or swallowing, but do not have motor issues. Now, dysphagia is difficulty in swallowing, encompasses the disorders of swallowing in general. It may arise from mechanical, neurological, or gastrointestinal disorders, traumatic injuries, and loss of organs due to surgery. And it can affect general health, psychological, and financial well-being. So how are they related? They both affect psychological well-being. A lot of these patients do end up with depression and suffer with loneliness. This is due to the social isolation and overall quality of life. A lot of this is centered around mealtime. This used to be something that everybody gets to enjoy, but mealtime can be pretty difficult. They do have a general health decline on both sides, poor appetite, poor diet, unable to swallow the nutrients they need. And both of them are a neurological issue. Neurofibrillary tangles and neuroplaques and granulovascular degeneration. Now, they are different in a lot of ways too. Alzheimer's is an issue of initiating feeding and swallowing, but don't have any motor issues until the later stages. But dysphagia is a motor issue of limiting specific food that are too difficult to swallow. Alzheimer's does have a language deterioration as it progresses, and dysphagia does not. Alzheimer's does not have an etiology. We actually can't even officially diagnose with Alzheimer's until autopsy, so you can see. You can't see that in a brain scan, but dysphagia comes from specific issues like the mechanical gastrointestinal issues that we discussed.
So who did this?
Sorry. Diagnosis. So how do we diagnose dysphagia? The screening of dysphagia. Screening identifies the need for further assessment and is typically completed before a comprehensive evaluation. A screening can be done by an SLP or another medical professional. An initial screening typically only takes 10 to 15 minutes. This screening looks at the following characteristics to determine the next steps: the general level of alertness, the general secretion levels in the mouth, so if the patient is drooling, throat or chest, awareness of secretions, if they could wipe away their own drool, their vocal quality, a history of any pneumonias, obvious reduction in oral motor control, and history of neurological injury disorder, and or a medical diagnosis. If the general screening shows signs of dysphagia, the next step is a clinical swallowing examination. This assessment may include instruments if the patient is able to. Things that limit instrumental use include low level alertness and poor fitting dentures. The comprehensive clinical swallowing evaluation is about this. First, they take a general background history. So like, what is the patient's current diet? Have they lost any weight recently? History of regurgitation, and a little bit more. Like if they ever had family history of dysphagia. Then they look at just an overall observation of the patient. Is the patient alert? What is the patient's respiration like? And like, what are the patient's symptoms and signs? Sometimes they ask the family for a little bit of a history as well. Ask the family like how they've been doing, especially like children. And then oral motor function, they look overall all the articulators. So they look at the general appearance of these articulators, like the lips, the tongue, and the palate. They note things such as symmetry, the ability to open and close the articulators, and are there any visible abnormalities? Next step would be the food and liquid food trials if they are able to. So like, how was the food liquid administered? This could be either by like a spoon, just like general how it was. And then they will go through liquids and they'll do like a thin liquid and they'll move to a nectar thick liquid, a honey thick liquid, and a pudding thick liquid. And then after that, they could also do food. The food, they would also just do different types. With liquids, there's also another test where you could do a cloth method if that is needed, like they can't swallow with a spoon. With the cloth method, they take a little like paper towel or like a piece of gauze and they'll dip it into 4 different types of liquid. So sour would be like lemon juice. And then like salty would just be like a saline solution. And they would just put that in their mouth and then put it in and see what was the patient's response to the food or liquid. So if the patient like coughed or anything like that, it would be noted. A blue dye test is done in patients with a tracheotomy. This is basically, they just put a blue dye in the tracheotomy and see if there's any regurgitation in that or aspiration that they can see. And then there's also instrumental tests. Some of these are the modified barium swallow test, which is also that picture in the top corner. The flexible endoscopic evaluation of swallowing, and an ultrasonography, which they're just all like instrumental tests.
How do we diagnose Alzheimer's? Usually a primary care physician will ask the patient they're experiencing symptoms, and then they'll also ask like family and friends questions regarding like their health, if they take any prescription over-the-counter medicines. They'll go over their diet, any of their past medical history, and then see if like whatever is going on is not allowing them to carry out their daily activities. And if there's been any changes in like behavior, personality, they'll administer a psychiatric evaluation to rule out any like depression or any other mental health condition causing or maybe contributing to these symptoms that they're having. And then they'll conduct a memory, problem solving, attention, counting, and language test to see if they can find anything else. And then they'll also want to check their levels, which include blood, urine, and any other standard medical tests that could be done to aid to see if that's causing any of these problems. And then they'll usually do a brain scan. It'll either could be like a CT, MRI, or a view of the brain. And a CT usually uses X-rays to obtain the cross-sectional images of the brain. The PET scan is the one that they look at most, which uses the radioactive tracers to detect the substances in the body. This will be looking for like strokes, hemorrhages, brain tumors, or any different degenerative brain diseases. On the PET scan, there's proteins that could be detected called amyloid proteins, which is a plaques, and it's associated with Alzheimer's. And there's also another hallmark abnormal protein as well that can be detected on a PET scan. There's no cure for this disease, and you want to try and get diagnosed the earlier the better, because if you catch it quicker, you're more likely to be able to participate in like clinical trials or other research studies testing new treatments, since there is no cure. And then after the patient may be referred to geriatricians, who are healthcare providers for more of the older adults, and they're more familiar with like aging and body changes. They could be sent to geriatric psychiatrists who specialize in mental and emotional problems with the older population. A neurologist, obviously, who specialize in the brain and the central nervous system, who can review the brain scans, and then neuropsychologists who can conduct those memory and thinking tests that would be ran. And then I just attached a picture down at the bottom just to show you what like is happening during Alzheimer's.
Okay, so for treatment, the primary goals of dysphagia treatment are to support adequate nutrition and hydration and return to oral intake, determine optimum supports to reduce patient and caregiver burden while maximizing the patient's quality of life, and develop a treatment plan to improve the safety and efficiency of the swallow. Treatment options and techniques. There are some called maneuvers. Maneuvers are specific strategies that clinicians use to change the timing or strength of particular movements of swallowing. Some maneuvers require following multi-step directions and may be appropriate for patients with cognitive impairments. Some examples of maneuvers include the effortful swallow, Mendelssohn maneuver, and the serpoglottic swallow. There's also swallowing exercises, which include exercises of the lips, jaw, tongue, soft palate, and larynx, and respiratory muscles to improve function. Swallowing exercise examples include laryngeal elevation, tongue hold, Masako maneuver, and the shaker exercise.
Some more treatment options are diet modifications. Food can be modified for the texture to facilitate a safe oral intake. And then since individuals with the disease tend to hold food orally, increasing saltiness, sweetness, or spiciness of the food can help the reflex kick in. Electrical stimulation may be used. The use of electrical stimulation and EMG biofeedback has been shown to improve swallowing function by stimulating the nerves. And then equipment or environmental modifications, adaptive feeding equipment, such as lids, flatware, and plates may be used to accommodate limited range of motion and swallowing difficulties.
So as an SLP, our scope doesn't allow us to like prescribe medicine or to do any surgery. So I wanted to stick with like things that we could do. So there's a lot of trends like such as biofeedback, which is pretty much teaching the patient how to control the swallow based off of like either like sensory things such as like sometimes they use like electromyography or esophageal manometry or the flexible endoscopic evaluation of swallowing, and sometimes mirrors, because this helps the patient sense or like receive information about their body because they're having a decreased sensation, so they can't sense. So that's what that would help. And then the rehabilitation, that's pretty much your exercises like to help improve range of motion, strength, function. And then we already talked about the specific strategies, which would be the maneuvers. And for in the future, I found some clinical trials which go off of the flexible endoscopic evaluation of swallowing, and they added in sensory testing, which is an extension which combines the endoscopic evaluation of swallowing with a technique that determines their like ability to discriminate between like different senses. And so it endoscopically delivers air stimuli to the mucosa to innervate the laryngeal nerve. So I thought that was interesting. I think there will also be a lot of new neuromuscular electrical stimulation because they've heard that that decreases aspiration pneumonia by stimulating those muscles. And that's all we have for you.